All right, we are live.
Thank you. Good morning, everyone. It is January 22nd, 2021, and this is the Senate Health and Welfare Committee. And just FYI, folks, I think Josh will be coming in sort of in about 10, 15 minutes. So we'll start, but we will start without him today. So Katie and Jen, thanks for being here. And I know you've put together some stuff that's going to help us know where we've been and maybe help us know where we might go. We never know. So, Jen and Katie, why don't I turn it over to you two, and then you introduce yourselves, the topic, and we'll go from there.
Great. I'm Jennifer Garvey from Legislative Council.
Katie McGlynn, Legislative Council.
And we have a presentation today of the bills that were passed by this committee in the 2019-2020 biennium. There are a lot of them. And so we'll just take you through. I think we have them, Katie, in numerical order by act. So we'll just take you through. It'll be a review for Senators Lyons and Cummings. It'll be maybe a bit of a refresher for things that were on the floor. Some of them didn't make it to the floor, but most of them did. For Senators Hooker and Hardy. And then when Senator Terenzini joins us, he'll get to see what you were working on. So I will share my screen. This is the one I will share. And it sounds like there may be—
Jen,
yes.
Just, I guess the FYI is that it's not yet up on our webpage. So
Right.
We'll stay glued to the screen. And as soon as Nellie gets the IT stuff figured out, we'll have it up on our webpage. So if there's anybody looking in, you're going to have to, you won't have it accessible for until it's up on our webpage. Okay.
Okay, can you see the screen with the presentation?
Yes, that's good.
Yes.
Great. All right.
Okay, so I'll start us off with the first act, which is Act 4. And this one is actually a bit complicated. So what this bill does is it amended a previous act from the previous biennium, 2 bienniums ago, which shifted regulatory authority for lead poisoning prevention programming from the U.S. Environmental Protection Agency to Vermont's Health Department. And after that act passed, the EPA reviewed the language, which it had to do as part of its approval to transfer the programming over. And the EPA requested a few additional changes before it would authorize Vermont's full assumption of the programming. And so this bill was to kind of update and fix the issues that EPA had identified before it could approve the transfer of authority over programming for lead poisoning prevention.
And do you want us to just pause for questions and kind of answer things as we go along if there are questions?
Yeah, I mean, I guess that's up to you. This one, I don't think, unless somebody has a burning question, we can just move ahead. But yeah, if you want to do that, that's fine.
Okay. The next one is Act 5. This was an act relating to extending the moratorium on home health agency certificates of need. So there is an existing moratorium on having a new certificate or a certificate of need for a new home health agency or for an existing provider to start offering home health services. The original moratorium was put in place, I believe, in 2010, and it kind of locks in place the existing set of home health agencies, all of which are now not-for-profit. So 2 years ago, in 2019, the General Assembly extended that moratorium until 2025, although you can lift it earlier, either by enacting legislation, or there's also, if you get some information from the Green Mountain Care Board that makes you want to lift it, it specifies that as well. Otherwise, it will go until 2025 unless you extend it. The next is Act 15. This is an act relating to miscellaneous provisions affecting navigators, Medicaid records, and the Department of Vermont Health Access. This was really the 2019 DEVA housekeeping bill. So it eliminated a duty that had been in statute, but I don't believe ever carried out, of navigators for the Vermont Health Benefit Exchange, or Vermont Health Connect, to help employers establish certain federally authorized tax advantage plans, Section 125 or cafeteria plans for people who are familiar with those. It just took it out of the list of their duties because it was not something that they were able to do or were doing. It made some clarifying changes to the statutes around the confidentiality of Medicaid applications and records. And then it transferred a report duty from DEVA to the Green Mountain Care Board. This is a report that is due in November of this year on what the impact of some statutory limitations on chiropractic and physical therapy copayment limits, what impact those limits on the copays have had on utilization of those services. Next was Act 17, an act relating to determining the proportion of healthcare spending allocated to primary care. And this directed the Green Mountain Care Board and the Department of Vermont Health Access to first identify which healthcare providers and services constitute primary care, which itself is a pretty weighty issue, and then determine the percentage of healthcare spending currently allocated to primary care by certain public and private payers, and then also by Vermont's healthcare system overall. And that report on those percentages and some related information was due last January, and we've included a link to that report if you wanted to go. And I understand there may be issues clicking on links in PDFs, so if you need help getting to the or using these links, let us know and we can help you.
So, and I want to flag this report because I think it might be useful as we go forward and start talking a little bit about our healthcare reform initiatives, to come back to this report and look at it together. So let's just flag that one for a future time.
All right, the next one deals with restricting retail and internet sales of electronic cigarettes, which are called tobacco substitutes in the statutes, liquid nicotine, and tobacco paraphernalia in Vermont. And this prohibits anyone from causing these tobacco substitutes, what we call e-cigarettes in statute. It prohibits anyone from causing e-cigarettes, substances containing nicotine or otherwise intended for use with e-cigarettes, or tobacco paraphernalia that is ordered or bought by mail, by phone, or over the internet to be shipped to anyone in Vermont other than a licensed wholesale dealer or retailer. And it also prohibits anyone from selling these items unless the person is a wholesaler or bought the items from a wholesaler. So this is really prohibiting the direct sale of e-cigarettes and liquid nicotine and things like that to Vermont consumers. And I was on the Vermont Attorney General's website just recently for a different purpose and saw that there was a settlement they had recently entered into with an online retailer specifically for violation of this statute. So some enforcement work appears to be ongoing. Oh, me again, sorry, Katie. This is Act 26, an act relating to the Rural Health Services Task Force. This created a 14-member Rural Health Services Task Force to evaluate the state of rural health care in Vermont and look for ways to sustain the system and ensure it provides access to affordable, high-quality healthcare services. And they submitted a report that, again, we've linked to last January. And Katie, the next two pieces of this are mental health. I'm happy to cover them, but I'm also happy for you to do it if you want.
Sure, I can jump in. So there was also a requirement that directed the Department of Mental Health to evaluate and determine mental health bed needs for residential programs across the state. And that report was due by December 15th, 2019. So there's a link to the report. It also required the Department of Mental Health, in collaboration with community service organizations, to initiate efforts to increase the number of affordable housing opportunities for individuals with mental health needs by potential funding sources for supportive housing and maximizing the use of Section 8 vouchers. And it specified that if funding was available to invest in affordable housing opportunity, expresses the legislative intent that the funds were to be used to create new options for affordable permanent housing around Vermont based on evidence-based supportive housing models.
So just, I want to just stay here for a second, but I'd ask you each to read the Rural Health Services Task Force report And then look also at the other report related to mental health. As we go through the bills, it brings back all these wonderful memories. So, but the content of the bills was shared between House and Senate, and that's probably true for every single bill we look at. But please do look at those reports.
All right, the next one is Act 27, and the title pretty much says it all. This is an act relating to increasing the legal age for buying and using cigarettes, electronic cigarettes, and other tobacco products from 18 to 21 years of age. So this was the bill that raised the smoking age from 18 to 21, and it was effective September 1st, 2019.
Next was an act relating to limiting prior authorization for Medicaid-assisted treatment. So this prohibited health insurance plans from imposing prior authorization requirements for counseling and behavioral therapies associated with MAT, and also for prescribing drugs for patient receiving MAT if the dosage prescribed was within the FDA dosing recommendations. It also required health insurance plans to ensure that at least one medication from each drug class approved by the FDA for treatment of substance use disorder was available at the lowest cost sharing tier of the plan's prescription drug formulary. And lastly, it required DVID to submit reports to the General Assembly annually between 2020 and 2022 regarding prior authorization processes for MAT and Medicaid. And that report touched on the claims received and the length of time to respond to the claims. And so you'll see that you have a link for the 2020 report on this page.
Right, and I did check just again this morning. I didn't see the 2021 report available yet.
Wait,
The next one. Oh,
sorry, Jen. This is Ruth. I spaced out a little bit while you were talking. I'm sorry. It happens. Could you tell me what the goal was for this bill? I sort of remember it, but I'm trying to, is it because there were too many prior authorizations required before people got MAT services, and so this was to cut down on the requirements for prior authorization? Is that basically what the impetus for this was?
My recollection is that. Oh, Katie, if you want to go ahead.
I was going to say that, but also standardizing across health insurance plans, the pre-authorization requirements for MAT was also part of it. And then,
as I recall, some of the issue was that there was real concern about putting any barriers up to somebody who was ready to engage in treatment for substance use disorder, that if they had to wait to get prior authorization from their insurance company, that might prevent them from moving forward.
Okay. That was what I thought, but I wanted that. Thank you for clearly stating that. And I will try not to space out again.
That's all right. Feel free to ask questions. We appreciate your honesty. All right. The next one is Act 47. Actually, this was written or drafted by Bryn Hare in our office. So if you have deep questions about it, we may send you to her for this and at least one other. But this is established as a fundamental right. This is an act relating to preserving the right to abortion. It established as a fundamental right the right to choose or refuse contraception or sterilization, and the right to carry a pregnancy to term, to give birth to a child, or to have an abortion. It prohibits law enforcement from prosecuting an individual for inducing, performing, or attempting to induce or perform the person's own abortion. It prohibits a governmental entity from denying or interfering with a fundamental right as established by the Act, from depriving a person of the choice to have an abortion, from interfering with or restricting a person's choice to have an abortion, from prohibiting a healthcare provider acting within the scope of their license from performing an abortion, and from interfering with the choice of a healthcare provider acting within the scope of the provider's license to provide an abortion. And finally, it establishes a private right of action in Superior Court for a person who is injured as a result of a violation of the Act. So for those of you who are in the legislature, this may look familiar should look familiar from 2 years ago.
Just a heads up, Nellie has put this up on our webpage, so you can access it. And I was sending Josh a message, but I'll say it. Josh, we're going through bills that we passed last session. And welcome.
Right,
Okay.
so
Thank you,
this is,
thank you, Senator. Appreciate it.
Okay.
these are acts that were passed in the 2019-2020 session that came through this committee with a couple of exceptions and we'll note where they didn't actually, committee didn't actually have possession, but worked on the bill. And then there's a list at the end of bills that passed this committee, but did not make it all the way through the process to become an act. So all of these that we're going through right now were passed and signed into law or became law and were enacted.
Thanks for the clarification.
We've made it up to Act 52 from 2019, which had to do with social service integration with Vermont's healthcare system. It requires the Agency of Human Services to submit a plan to the General Assembly related to the coordinating and financing of delivery of Medicaid home and community-based services with the all-payer financial target services, including future plans for integration of long-term care services with the ACO. And that report has been submitted. It also requires the Director of Trauma Prevention and Resilience Development that this committee created, I want to say 3 years ago now, to serve as a resource in ensuring that new models used by community social service providers are aligned with the state's goals for trauma-informed prevention and resilience.
That report, is that a last year report?
You know, I think it's on our list that we're going to go through
We're
with
going to
you.
go
So I
through
think it
that.
must have
Yeah,
just come
okay, I
in.
thought so. I think I just, okay, good.
And sorry, we didn't put a link in there, but we can update that.
Don't worry about that.
right.
Sure, we'll get to it.
The next is Act 53, an act relating to informed healthcare financial decision-making and the consent policy for the Vermont Health Information Exchange. So when we get there, the Health Information Exchange is what Vital runs. This is for the electronic health record. So something different, even though they both use the term exchange from the Vermont Health Connect exchange. This act specified that hospital and ambulatory surgical center patients must receive itemized, detailed, and understandable explanations about their charges and information about the financial assistance and billing and collections practices for the hospital or the ambulatory surgical center. It required the Green Mountain Care Board to collect and review certain data from psychiatric hospitals, to examine healthcare price transparency initiatives in other states, and to recommend potential modifications to the healthcare billing processes here. And the Green Mountain Care Board's report on transparency initiatives and billing processes was due by November 15th, 2019. And there's a link here for that. And then this is the Health Information Exchange part. It changed the policy so that as of March 1st, 2020, patients' electronic health information in the Vermont Health Information Exchange became accessible to healthcare facilities, healthcare professionals, and public and private payers, unless the patient affirmatively opts not to have their information shared in that manner. So prior to March 1st, 2020, it was an opt-in, where a patient had to affirmatively choose to have their electronic health records be viewable by their treating providers and their payers. On March 1st, 2020, it changed to an opt-out so that everybody's information in electronic health records would be available to their treating providers for purposes of delivering care to them. So not just to go in and look around unless the patient opts out. DVA had to administer a stakeholder process to develop an implementation strategy for the opt-out consent policy and provide updates to the Green Mountain Care Board and the General Assembly. And those updates were submitted by August 1st, November 1st, 2019, and then a final report came in last January.
Can I just ask, who's responsible for determining if the bills, the itemized and detailed and annotated bills are understandable?
I have to go back and look and see exactly where we codified that before I can give you an answer. to that. Let me refresh my recollection and I'll follow up with you.
Thank you.
I'll just say one thing about Vital. You mentioned Vital and the VHI. When the IT problem, cybersecurity problem happened at the UVMMC and all of their and some of their affiliates. The only thing that kept clinicians able to access patient information was Vital, so they could switch to Vital. And I was talking with one primary care physician who said, without that information, it would have been really difficult to take care of patients. So I just want folks to know that it doesn't mean that. I mean, we do have, in many ways, depending on what hospital or practitioner you go to, Vital serves as a backup. So there is some redundancy in the system. I don't think we need to debate whether that's good or bad right now, but that Vital was very helpful during the cybersecurity glitch.
All right, I'm ready to move to the next one. Next one is Act 55, an act relating to licensure of ambulatory surgical centers. And this act established licensure requirements for these ambulatory surgical centers. It requires the Green Mountain Care Board to collect and review certain data from ambulatory surgical centers until January 16th, 2026, and to describe its oversight of the centers in the board's annual reports between 2021 and 2026. And it specifies that the Green Mountain Care Board is not required to collect, review, or report further data on an ambulatory surgical center that was in operation on January 1st, 2019, following submission of the Green Mountain Care Board's 2023 annual report. So this was creating licensure requirements prior to sometime in 2019. I think we only had one ambulatory surgical center in the state. There's an eye center in the Chittenden County area. There was the second one that came online. There was a lengthy certificate of need process and a lot of conditions placed on the certificate of need for that ambulatory surgical center by the Green Mountain Care Board. So this is looking at continuing to get information on these ambulatory surgical centers for an extended period of time, but for the one that was already in existence, it's a shorter time for the Green Mountain Care Board to be reporting on their information. Next, I'm sorry, the font is small. There's a lot in this one. This is Act 63, an act relating to health insurance and the individual mandate. This created a requirement that Vermont income tax filers must indicate on their income tax returns whether they maintained minimum essential coverage or were exempt from that requirement. Anyone who indicated they have or had minimum essential coverage for the taxable year must be prepared to provide a statement of coverage to the Department of Taxes upon request. And then it directs DEVA to use information from the tax department about who doesn't have minimum essential coverage in order to provide targeted outreach to help those people find affordable and appropriate coverage. It also added a number of consumer protections that are in the Affordable Care Act and also codified them in Vermont law. So that included the ban on pre-existing condition exclusions and annual limitations on cost sharing, a ban on annual and lifetime limits on the dollar amount that a plan will cover for essential health benefits, prohibition on cost sharing for certain preventive services, and a requirement to allow young adults to stay on their parents' plans until they're 26 years of age. Then separately, it allowed, this dealt with association health plans. And so some of this happened in the committee down the hall, the finance committee, but was also looked at by this committee. It allowed association health plans that were operating in 2019 to be renewed if allowed under federal law, but not to enroll new members. And it prohibited new association plans for plan years 2020 and after. It prohibited licensed brokers, insurance brokers, from accepting payment for enrolling Vermonters in arrangements involving the sharing of health-related expenses that don't qualify as insurance under Vermont law. So most people will have heard of the healthcare sharing ministries. So a broker could not take a broker fee for enrolling a Vermonter in a healthcare sharing ministry. It directed the Agency of Human Services to look at how to make health insurance more affordable, explore imposing some higher Medicaid copays on certain services for people in the higher end of the Medicaid eligibility area threshold, in order to make insurance subsidies available to people who were of lower income but above the Medicaid threshold, and to explore the potential for a regional publicly financed universal healthcare program with other states. And that report was due by December 1st, 2019, and is available on the website. And it also directed the Agency of Human Services to recommend by December 1st, 2019, whether Vermont's insurance market structure should be modified. And those recommendations are in that same report with a link here as well.
So that report, the last one on the market modification, market structure modification, might be helpful just to look at, just for educational purposes. So
Just a quick question, Senator Lyons, if it's okay. Who would be exempt from carrying the insurance?
As I recall, we tied this to the federal requirements for minimum essential coverage. And so if people did not have enough income to be required to file an income tax return, I believe they are exempt. And I'm just trying to look this up. It has been a while. Let me see if I can quickly pull it up and let you know. All right. So somebody who has is part of an established religion that does not believe in receiving health care, an individual who is not lawfully present in the United States, somebody who is imprisoned. Everyone else is what is defined as an applicable individual. And so everyone who has to file, who files or is required to file an individual income tax return as a resident of Vermont has to indicate on the form whether they have the coverage.
Okay, thank you.
And I have a question also, if that's okay.
Yep, go right ahead.
Okay, Jen, the reports that were due December 1st, or I know that we had a lot going on last session after COVID, but were there any recommendations that this committee or the legislature, did we act on any of those recommendations? Did they make any recommendations that were worthy of acting on?
As I recall, they may, I won't weigh in on whether they were worthy.
Okay, of
but
course, sorry.
They did make, no, that's okay. The chair can. They did make recommendations. And I think there was, I know there was a lot of interest on the House side in trying to move forward with the potential for some around affordability of health insurance, but ultimately nothing was moved.
Right, because we had a pandemic to deal with, but.
I think there were also difficulties in figuring out how to craft something that was satisfactory and that and also mindful of cost to the state.
Right. Okay. Thank you.
But everything that we do is worthy, Senator.
Well, of course. I was questioning whether the reports were worthy, the recommendations were worthy, not our actions.
Okay, go ahead. Sorry. Go ahead, Jen and Katie.
And you may want to take a look at the recommendations. I think some of them were more laying out options than specifically making recommendations.
Okay. The next act actually did not come to this committee in terms of the committee having possession of it. This, I believe Senate Education took the lead on this, so Senator Hardy will be the expert on this bill in the room, but I believe that Senate Health and Welfare did do a review of this legislation. And it's an act relating to testing or remediation of lead in the drinking water of schools and childcare facilities. It requires school districts, supervisory unions, independent schools, and child care providers to test for lead in the drinking water from outlets in each building or facility it owns or controls. It requires our health department to pay to conduct the testing of samples taken by schools and child care providers. And if the testing indicates that lead is present in drinking water from an outlet at or above the action level, which was 4 ppb, then the school or child care provider was required to take the outlet out of service and conduct remediation to eliminate or reduce lead in the drinking water from the outlet. Secondly, it was required to notify parents, guardians, and staff of the remedial action. Third, it had to submit a lead remediation plan to the health department. And fourth, notify the department when the plan was complete. And this required that the state was to pay the actual cost of replacement of outlets that were at or above the action levels, up to a capped maximum amount per type of drinking water fixture. And it requires the health department to adopt rules to implement the testing program.
So I'd like to make a comment. So the last line there talks about adopting rules. And I happen to be on the Legislative Committee on Administrative Rules. When the rules came through, there was significant debate about the definition of outlet. And so this is just to let you know, when we put in to make rules, if our language isn't absolutely, totally, completely clear, it can cause problems down the road. In this case, schools were concerned about only looking at outlets that children or adults might drink from, so drinking fountains and so on. But some of the outlets were for custodial purposes only or sprinkling the grounds. And so there was some resistance on the part of some schools to put that extra cost in. So that was kind of a fun one. I think Katie, maybe you remember how many rules committees that one went through, how many different meetings. I
remember reviewing it, and I remember the debate. It was controversial with regard to that definition.
Right. And that was that's just one element that was there, but it was very interesting. So not to interrupt more, but I just thought I would share with you what happens after we pass a bill like this, where it says rules to implement. Then there's a lot of detail that goes on in a whole another process.
Yeah, and we had that debate in the Education Committee as well. So it was not just through the rules process. It was contentious.
So you just sent it off to us.
Well, so there was a lot of debate about there are sinks in classrooms that are not necessarily used for drinking and et cetera. But we wanted to make sure that those were remediated because kids could still potentially drink out of them, even though they weren't.
Oh, we heard it. You did a good job. I'm not criticizing the bill at all. I'm just saying that there can be confusion regardless of how hard you work on a bill.
Yeah. Absolutely.
Senator Hooker.
So in this case, was it clarified?
Yes.
Under rules, and do they?
I think the Department of Health won the argument.
So they are included. All of the
outlets are included.
Okay, thank you.
I don't remember the exact resolution, to be honest with you. It was a long time ago.
Drinking out of the hose.
Yeah, nobody. Yeah. We're drinking out of the hose. Okay.
Yeah.
Okay. The next act was an act relating to the regulation of toxic substances and hazardous materials. Mike O'Grady worked on this bill with the committee. It establishes the Interagency Committee on Chemical Management to evaluate chemical inventories in the state, identify potential health risks to human health and the environment from chemical inventories, and propose measures to address risks from chemical inventories. It amends the Chemicals of Concern to Children program in terms of the required information that a manufacturer has to submit to the department when fulfilling the program's notice requirements, specifically with regard to submitting a product's brand name, a product's model, and a universal product code when it might contain a substance on the list of chemicals of high concern to children. And lastly, it amends the criteria under which the Commissioner of Health may regulate the sale or labeling of a child's product containing a chemical of high concern to children. Act 82 is an act relating to substance misuse prevention. This act establishes the Substance Misuse Oversight and Advisory Committee, which was tasked with improving the health outcomes of all Vermonters through a holistic approach to substance misuse prevention and addresses all categories of substances. As Senators Lyons and Cummings might remember, this act consolidated a number of existing committees that dealt with prevention and substance misuse and created this one Oversight and Advisory Committee. The act also establishes a manager of substance misuse prevention to staff the committee, and this manager is also responsible for completing an inventory of substance use disorder programming in the state, which I believe is being submitted this January. The act also created a chief prevention officer within the Agency of Administration to coordinate across state government in collaboration with community partners, policies, programs, and budgets to support and improve the well-being of Vermonters through prevention efforts. Specifically, the chief prevention officer is responsible for identifying and coordinating prevention initiatives across state government and among community stakeholders, examining promising prevention practices in other jurisdictions, and also improving Vermonter well-being by considering population prevention measures.
So yeah, this bill is, I think, really fundamental to some of the work that we're doing in healthcare with primary care and prevention, as well as working across agencies and departments. Katie, remind me, I do believe that we included a diversity component in there to keep track of racial and ethnic differences. Anyway, we'll go back and look.
I'd have to recollect.
Yeah.
I can't recall. I'd have to review the bill
Okay.
again.
And then the chief prevention officer in the governor's office has not yet been appointed. And that's what I was asking Mike Smith about yesterday. So we will, we're going to spend some time with folks about the prevention council and the new manager and hopefully a new chief prevention officer. But COVID got in the way. So this one has been slowed down significantly. Go ahead.
Senator Lyons, was that the trauma?
No,
position
and the
had a
trauma,
different position?
the trauma person is trauma-informed program person is in the Secretary of AHS office. And that's a different, has a different charge. And there's no one to invite in right now, but we will try to get at that one as well, because it all fully integrates with prevention and trauma, prevention of social determinants of health, and then informing every aspect of government about trauma-informed practices and so on. So we'll look at those. Those are good.
The next bill you worked on this bill with Bryn Hare from our office, an act relating to prohibiting female genital mutilation or cutting. This prohibits the act of female genital mutilation or cutting, with exceptions. First, for medically necessary procedures performed by a healthcare professional, or a procedure performed by a healthcare professional, midwife, or trainee on a person in labor or who has just given birth for medical purposes connected with the labor or birth. And it imposed a 2 to 10 year term of imprisonment and a $500 to $20,000 fine for violating the statute.
Senator Lyons, can I ask a question?
Absolutely. Go right ahead.
This one jumps out at me, and obviously it's very serious. I just don't understand how did the committee take a topic like this up?
Yeah.
I don't know how to word my question, but it just seems like
It seems
a little
strange.
help here with Senator
Yes.
Lyons.
Yes, it does seem
Yes.
strange. I agree. I agree with that. It seems like we're directing medical practice in some way, but the reality is that there is a culture in African countries where girls are mutilated, genitally mutilated when they're quite young, and it's part of what happens. It's part of their cultural practices, but it can cause significant long-lasting harm, both psychological and emotional and physical. So this was brought to us by folks from African countries, immigrants and migrants who come to our state, and we did take it up. We didn't get any pushback on this one. It's really
No,
to protect kids. Yeah, it's a hard one because it is just one procedure. I understand.
Not being here, I was just surprised to see it on the screen, but let me thank you and the committee for taking it up after you explained it to me. It seems like certainly a very worthy piece of legislation. So thanks for the explanation. And I didn't even know that was a thing. So I'll leave it at that. So thank you.
You wouldn't know it unless I worked with someone who escaped her Nigeria with her daughter before her daughter was mutilated. And, you learn about these things.
Sure.
But yeah, no, thanks for your comments.
Thank you.
Okay, the next one we have is Act 91. This is an act relating to Vermont's response to COVID-19. So this is what the House passed just before the State House shut down in mid-March. And then this committee took it up initially by conference call. We were all on various phones trying to work on the language with the advocates, and before we even got the Zoom up and running. And I did do a deep dive on this yesterday with House Healthcare, going through all of the expiration date or the deadlines, the dates where various provisions expire, so we can do that same kind of thing on a future day if that would be helpful. But for now, the overview of the Health and Human Services provisions. The Act overall provides administrative and healthcare provider flexibility in responding to the COVID-19 pandemic. It allowed the Agency of Human Services and the Green Mountain Care Board to waive or modify certain regulatory processes and requirements as needed to prioritize direct patient care, allow flexible staffing, and preserve provider sustainability. It directed the Department of Financial Regulation to consider adopting emergency rules, which it did, to expand insurance coverage and reduce out-of-pocket costs for COVID-19 diagnosis, treatment, and prevention, to modify or suspend deductible requirements for prescription drugs, and to expand access to and reimbursement for healthcare services delivered remotely, including by audio-only telephone. And that'll come up in a later act as well, and there's a report on that piece. It allowed patients to refill maintenance medications early so that they could make sure they had enough at home and didn't have to keep going back out to the pharmacy. It allows pharmacists to extend prescriptions for maintenance medications and also to substitute a substantially equivalent prescription drug if a prescribed medication was unavailable. There was a lot of concern, and some of it played out early, especially early on, about lack of availability of certain medications or certain drug component ingredients that would make it so that the drugs themselves might not be able to be manufactured. So this gave pharmacists some more flexibility with how to fill a prescription. It allowed recently retired Vermont providers and providers licensed in other states to deliver healthcare services to Vermonters using telehealth or as part of the staff of a licensed facility or under a temporary license. And it gave the Office of Professional Regulation and the Board of Medical Practice flexibility to waive certain requirements during a state of emergency. It also expanded health insurance coverage for telehealth, including teledentistry and services delivered by store and forward means. And until January 1st, 2026, so there's a sunset in here, it requires health insurance plans to reimburse providers the same amount for the same services, whether they are provided in person or by telemedicine. And then this last piece, it allowed the Commissioner for Children and Families to use some additional money from their fiscal year 2020 appropriation for the Child Care Financial Assistance Program to help child care programs at risk of closing due to financial hardship. And again, this was one of several child care provisions throughout the pandemic.
So, and this is not the one that has the extended deadlines.
Right, Act 140 is going to extend.
It's going to show. So I'll save my comments till we get there.
Okay.
Okay, good.
And then, as I said, it may be useful to take a look, like I did for healthcare yesterday, or I can just send you the document that I use that gives some more detail on each of these and specifies when they will sunset if you don't do something to extend them.
Yeah, I think we should do that. And I'll say it now. I did ask Jen to introduce a bill that would extend some of the sunsets, given that we haven't exited the emergency as yet. So we will be, and we will take this up. I think this will be an important part of our response work, in addition to all the funding pieces that we'll be working on, but this will be important as well. And there may be some things that we can add in. I've already got an idea or two of things we can add in going forward. And just to finish this off, this section off, I have talked with House Committee on Healthcare, and we'll sort out how we proceed with this, who does what when, and maybe there'll be an opportunity to meet together again. I don't know. We'll just see how that goes.
So the next one we have is related to the pandemic, although you can't necessarily see that just from the words here. So this is Act 107, an act relating to allowing remote witnesses for advanced directives for a limited time. Just a little background on this. Generally, when someone is executing an advance directive, which is a document where they can set forth their wishes for their healthcare, their treatment or lack of treatment if they're unable to make decisions for themselves, and also identify one or more people to serve as their agent to make healthcare decisions for them if they're not able to make their own. So in general, that document requires 2 witnesses to witness the principal signing it, and it all happens in person. Everyone signs the same document. There was concern about some advance directives that had been executed under somewhat different circumstances early in the pandemic, and so at this point, when this language was being worked on, it was really like late May, early June, and so looking to kind of bless the ones that had happened earlier, and then set some little bit more stringent restrictions for the ones going forward. So an advance directive executed between February 15th and June 15th of 2020 would be deemed valid even if one or both of those required witnesses was not physically present when the principal signed, because people were not congregating. If the principal and remote witnesses were known to each other, the remote witnesses were informed about their role as witnesses, and the principal included each remote witness's name and contact information on the advance directive. And if an advance directive was executed under those circumstances, it would remain valid until June 30th of this year, June 30th, 2021. So that was the ones that had already happened, February 15th to June 15th. And then the next bullet is an advance directive executed between June 15th of 2020 and June 30th of 2021 would be deemed valid even if one or both of the witnesses, again, was not physically present when the principal signed, if the principal and remote witnesses were known to each other. And then this is the new piece. If based on video or telephonic communication with the principal, the remote witnesses made certain attestations that the principal seemed to be of sound mind and to know what they were doing. And the principal included the remote witness's name, contact information, and this is the other difference, their relationship to the principal on the advance directive. And an advance directive executed under these circumstances would continue to remain valid indefinitely unless the principal amended or revoked or did a new advance directive. And then the last bullet deals with an additional requirement in the advance directive law that if the principal is a patient or being admitted to a hospital or is a resident or being admitted to a nursing home or residential care facility, when they're doing their advance directive, that there also be somebody, and there are some certain requirements for who can perform this role, who explains the nature and effect of the advance directive to the principal. And we kind of shorthand refer to this person sometimes as the explainer for the advance directives. So this says an advance directive executed between February 15th, 2020 and June 30th, 2021. So across that whole period, while the principal was being admitted to or was a resident or patient of a nursing home, residential care facility, or hospital, as applicable, would be deemed valid even if this explainer who explained the nature and effect of the advance directive to the principal was not physically present, as long as they had communicated with the principal, communicated this explanation by video or telephone. And then the validity of these advance directives is tied to when they were executed under the provisions above. All good on that one? All right. Then we have Act 118, an act relating to regulation of long-term care facilities. And this was a bill that was brought to the legislature by the Department for Disabilities, Aging and Independent Living, DAIL, and the Office of the Attorney General based on a long-term care facility receivership case that they'd had recently. So this would address some of the issues that came up in that case and make things clearer going forward. So first, it established an actual definition of insolvent for purposes of determining whether a long-term care facility should have a receiver appointed. And we use the same language that is in the Uniform Commercial Code. Then it specified that when a court is deciding whether to appoint a receiver, the court's determination of whether the grounds for receivership have been met need to be based on what the facility's condition was at the time the complaint requesting appointment of the receiver was filed. So whatever the grounds were for someone filing the complaint thinking that a receiver was necessary, that's what the court should look at, and not any changes that may have been made since that filing. That was not clear in the law prior. And then finally, it allows DAIL to take immediate enforcement action when necessary to eliminate a condition that can reasonably be expected to cause serious mental harm to the residents or staff of a long-term care facility. So serious mental harm is the new piece. Under prior law, DAIL could only take this immediate enforcement action to eliminate a condition if it was reasonably expected to cause death or serious physical harm. So this adds serious mental harm as well.
So I think, unfortunately, this bill is an excellent bill. I mean, we had that financial problem with one of the long-term care facilities in my district. And now we're seeing another long-term care facility reported that has caused some medical harm to their residents. We may want to, we will try to get at that a little bit with DAIL. It's, I don't know if you've read about Elderwood or not, but for committee members, if you haven't read, I'll send that article along to you.
You send to me too, if you would.
I will be happy to, and I'll send it to Katie.
All right. Our next act is Act 123, an act relating to physician assistant licensure. And this committee did a lot of work on this bill as well. So it revised the physician assistant licensure statutes and moved the profession from a supervised model, which is where the physician delegated duties to a physician assistant who was under the physician's supervision under a delegation agreement to a collaborative practice model where the physician, either independently or on behalf of a group practice or facility, enters into a practice agreement with a physician assistant. And this is really reflecting the change in the role of the profession of physician assistant from where it started, which the name physician, or it used to be physician's assistant, kind of indicates that they were working for and under the supervision of a physician, to a more independent mid-level practitioner who practices with more autonomy, but would still have this practice agreement with a physician and either independently or on behalf of a practice or facility. And just so you know, as we're going through here, the physician assistant still cannot operate their own practice. So they have to be affiliated with another provider or with a facility, but this is giving them some more autonomy. So it specifies that physician assistants are responsible for their own medical decision-making. Formerly, the physician who was supervising them had that liability. And that the existence of a practice agreement alone does not make the participating physician legally liable for the physician assistant's actions or inactions. So if the physician had some more involvement, there could be liability there, but just the mere existence of the practice agreement does not create liability for the physician. It says that physician assistants are to be considered primary care providers when they're practicing in specialties for which physicians are considered primary care providers. It repeals a statute that requires a physician or a clinic or hospital to post a notice if it uses physician assistants. It requires health insurers and Medicaid to reimburse physician assistants for a service if the same service would be covered when delivered by a physician. Doesn't necessarily have to be in the same amount, but it does have to be reimbursed or paid. It allows physician assistants to bill for and receive direct payment for their services, so they wouldn't have to bill under somebody else's code. And it directs the Department of Health to update the Board of Medical Practice rules on physician assistants by July 1st of this year to reflect all of these changes. The next one is Act 126, an act relating to the Board of Medical Practice and the licensure of physicians and podiatrists. Little asterisk down at the bottom, if you can't see it, says Senate Health and Welfare did not take possession of this bill, but they did review it. And so I thought I would include the provisions here. It updated some language and terminology relating to the Board of Medical Practice and physician licensure throughout those statutes. It updated the qualifications for physician licensure and revised the triggers for when a licensee's employer must report unprofessional conduct to the Board of Medical Practice. And this was probably the most contentious part of the bill. It modified provisions relating to the Board of Medical Practice's powers and duties and to its complaint investigation and hearing processes. Some of that was just reorganizing and updating those. It created a new non-disciplinary financial penalty of up to $250 for violations of statutes and Board of Medical Practice rules of an administrative nature. It required the Board of Medical Practice to post its investigation operations manual on its website by July 1st of last year. Amended some provisions relating to renewal of a podiatrist license. It did what I think was sort of an oversight, fixed an oversight. It added the Board of Medical Practice to the existing description of the professional licensing boards that are entitled to inspect prescription records related to regulated drugs. So for whatever reason, those statutes only referred to licensing boards attached to the Office of Professional Regulation, which I think was a holdover from when the Board of Medical Practice was part of OPR. And then finally, it modified Board of Medical Practice rulemaking requirement around maintenance of licensure rules for podiatrists, physicians, and physician assistants.
So just so you know, this bill was in GovOps. GovOps does have oversight of professions. Maybe you want to explain that a little bit, Jen. And we have our jurisdiction includes the Board of Medical Practice and other areas. So just briefly, maybe give the thumbnail.
Yeah, I mean, I think sometimes bills can go
Either
either
way.
place. And so as you saw the prior act that we looked at around physician assistant licensure, which is a profession regulated by the Board of Medical Practice, came to the Senate Health and Welfare Committee, but the bill on the Board of Medical Practice and licensure of physicians and podiatrists went to the Government Operations Committee. So sometimes it's hard to know where they're going to go. And this is why this committee did take an unofficial look at the bill. But the Board of Medical Practice is attached to the Department of Health and regulates MD doctors, medical doctors, but not doctors of osteopathy. Those are regulated by the Office of Professional Regulation. In practice, you probably don't know much in the way of a difference between what MDs and DOs do, but their training is somewhat different and they attend different professional schools for that. So the Board of Medical Practice does allopathic physicians, that's the MDs, physician assistants, podiatrists, radiology assistants, and anesthesiology assistants, I believe. And the other healthcare professions are all attached to the Office of Professional Regulation and their board. So nurses, the mental health professions, other than psychiatrists, because those are physicians regulated by the Board of Medical Practice. So there's a bit of a split there.
And just whenever we see a bill, and I ask, we keep an eye on bills that relate to medical practice, regardless of the practitioner, and work if the bill is in GovOps, we work with GovOps. If there is a increase or change, decrease, increase, change in the scope of practice for a practitioner, we pay very close attention to that. And that is part of what we should be doing. So it sometimes gets a little bit contentious, but I have to say that it's been a very good working relationship all the way around with OPR, Board of Medical Practice, and our committees. So.
And the chair's comment about looking at things that are in government operations, especially around scope of practice changes, is actually also a good reminder that there was a bill, the big OPR bill from last year expanded the scope of practice for pharmacists to allow fairly extensive prescribing, but under certain parameters. So either based on an agreement with a sort of a standing agreement with a prescriber, or pursuant to protocols to be issued by the Commissioner of Health.
Right, and that's in another bill. I'm trying to remember which bill. That was one of our last bills when we worked
Right,
very
so that was
hard on that.
that was OPR.
It was, yeah.
And there was also there had been on the House side, when we get to the bill on access to contraceptives, there had been a piece in there to allow pharmacists to prescribe contraceptives. That then was also in the OPR bill, and so it came out of yours, but that's one of the types of medications that they can prescribe under these new arrangements and rules, and I don't know what has been issued, if anything, in that area yet. I think the Commissioner of Health may have
I'm trying to remember.
other duties.
I don't know that, I don't know that rules have gone out, but maybe they have. There've been a lot. It's been a huge, heavy lift in the Rules Committee. Okay, LCAR, I mean.
Can I just ask why podiatrists are singled out in this bill?
And specifically in this bill, as far as the renewal of podiatrist licenses, this bill was came from the Board of Medical Practice. I mean, it was they're the ones who brought it to the legislature and asked for some updates. So they were asking for some updated language relating specifically to the renewal of podiatrist licenses. Some of it was terminology and some of it was making the same changes we were making in other bills to be specific about the extension for time to renew if somebody is deployed, for example, in the military when their license is out.
Okay, thank you.
Yeah.
Jen and Katie, I'm going to ask the question, do you want to take a little break? Do you want to take a 5-minute break? Is this a good time to do that? Or are you?
I would say that's up to you. We are on slide 20. No, what are we on? We're on slide 23 of 38. So if you would like a break,
Let's do
that
it.
sounds great.
It seems like, I think we'll probably get through everything, don't you?
Yes.
So why don't we take a 5-minute break, committee? And Nellie, you can put the other screen up and we'll just turn ourselves off for a few minutes and stretch. We are the Health and Welfare Committee. Okay. We're back. Jen, you can go ahead, put your screen up, I guess.
Okay.
Good. And we're on, you tell us what we're on.
Let
Oh,
me just
yeah.
find that. All right. Can you see that again?
Yeah.
Should be up to the next one. All right.
And I just, I need to say this because when you look at all the H's in front of all those bills, you think, gee, the Senate didn't introduce anything. But basically, we worked together hand in hand with both House committees. And we put together anything that had money in it at all began with the House, obviously, because it was going to, that's the way things start. And some of the money was going to be influencing budget. So we worked very closely with the House committees to put all of this stuff together. I just wanted you to know that. And frankly, we're going to try to do that again as we see what federal funds are coming to us.
Okay, so this act is Act 136, an act relating to healthcare and human services related appropriations from the Coronavirus Relief Fund. And just by way of sort of reminder for those of you who are here and for Senator Terenzini, so you're aware, and you may have already heard this, but this is the Coronavirus Relief Fund is the $1.25 billion that the federal government provided to the state under the CARES Act for to deal with coronavirus related expenses. And there were certain parameters in there that required all of the money had to be used for expenses that were incurred due to or as a result of the COVID-19 public health emergency. And they had to be to cover expenses incurred between March 1st and December 30th of 2020. Shortly before December 30th, 2020, they extended the deadline for when we can use the funds and incur those expenses until December 31st of 2021, although much of that money had already been appropriated and expended in accordance with what we had laid out, thinking December 30th was the act. So this particular bill, Act 136, appropriated $326,850,000 from the Coronavirus Relief Fund for healthcare and human services related expenses incurred as a result of the COVID-19 pandemic. And that included $28 million for the hazard pay program for frontline workers. There are additional appropriations that happened after that as well. There was a report on that due by January 15th that we have linked to here. There is the Healthcare Provider Stabilization Grant Program. That was a $275 million initial appropriation. And some of that money was actually returned and reallocated for other uses. And you heard some of this from Sarah Clark from the Agency of Human Services the other day. But there were reports due in August, October, and then a final report in January. And all of those have been submitted and are on the website. Then there was money for COVID-19 related health disparities. There was directive to the health department to use their existing enhanced laboratory capacity ELC grant and an additional 500,000, and then other amounts ended up being appropriated later. There was a report due on that in August.
And then there was language with regard to suicide prevention. At the time, DMH thought they would be receiving a federal grant. They did not receive that, and there was language in the act that specified that the department was to notify the General Assembly if they were not to receive the grant. And in the end, DMH ended up receiving both CRF funds and also additional general funds for suicide prevention. There was an appropriation.
I have a question for someone. I'm
Sure.
sorry to interrupt you, Katie.
That's okay.
Caroline, can I ask a question?
Of course. Now go right ahead.
Just for a better understanding, when the federal government allocated the state of Vermont X amount of dollars for the pandemic, that money was obviously dispersed to many different agencies and so on. Was the decision made by the governor's office or in conjunction with the House and Senate? How exactly was it determined where the money went, who got what, and whose final say was that? Was it the legislature?
Yes, because of the appropriation authority, the legislature gets to decide in most cases, how the money gets spent. Sometimes, I mean, grants come in that still get approved by the Joint Fiscal Committee even before those can be spent. But it was by appropriation, but there were different mechanisms set up so that some of it went through the full legislative process. Some of it was given to the Joint Fiscal Committee to make sort of more responsive allocations to the executive branch as needs arose. And then there has been some reversion and reallocation efforts. But the executive branch has been very involved in recommending how funds should be used, making proposals for how funds should be used, but ultimately it's the legislature or the Joint Fiscal Committee on behalf of the legislature approving those.
And
So
that joint fiscal committee, that's some of our colleagues, Senator Lyons, sit on that.
I'm not
Senator
on
Cummings has actually been the chair.
Okay.
And so, yes, it is all made up of your colleagues. It is House and Senate.
So that's where I need to strive to get to, then you're saying, Jennifer.
I'll leave that up to your ambitions, and you may want to talk to Senator Cummings about that.
so just
Thank you.
just in terms of what we're looking at right here, let me give you an example of how this happened. Early on, when we learned we were getting the 2 point something or the $1.25 billion, when we learned that, there are choices for that. One, we could just say all of that money is, we could say will be spent and determined by the administration. That's a choice the legislature can make. The legislature must appropriate the funds. So, and that was a decision that was made by us, who said we need to approve all expenditures from the coronavirus relief fund, that come to the state. So then we as a committee working with our colleagues in the House, we worked day and night. Initially, we worked right through weekends, and then we worked through every single day, long days. Our committee probably met a little bit more than others. We met with Human Services. We met with Healthcare in the Senate, in the House, rather, thank you. And then we looked at all the needs that were out in our community. So what did our providers need? What did our hospitals need? What do our designated agencies need? So we took what do our long-term care facilities need in terms of funding to get through the COVID emergency. And then we looked at the issue of disparities. We looked at food insecurity. We met with everyone. And then we took all of the money that we had that was given to us. And in the Senate, I forget what our bottom line was, but our committee was told, figure out how to spend $200 million. In the House, they were given more. And then we sat down together. The House came up with a proposal. Our committee looked at that proposal and we made a recommendation through a letter, and you can find that letter on our webpage from last year. And we sent our recommendations to the Appropriations Committee, and that really that resonated with them, and that served as the position for the Health and Human Services. So that's how that worked. We worked very closely with the administration as well as our community partners. And so it was fun.
So it sounds like this committee did have some influence as to where some of the funding went in conjunction with appropriations.
We had a lot of influence.
Oh, good.
And then in terms of meeting, I met separately with the chair of appropriations, and we talked a great deal about how the money should be appropriated to meet the needs in our community. And we will do that again. I think that probably it'll be a little bit easier this time because we sort of know what the issues are. So we won't have to dive in as far as we might have had to in the past, but we'll see. Senator Hooker, you have a question.
Yeah, yes, just a comment that as a member of the Economic Development Committee, we saw a chunk of money that had to be appropriated as well. And one of the problems, Senator Terenzini, with the initial CRF money was the timing and having to sort of get the money out the door really quickly. And so we didn't have the opportunity to suggest as detailed recommendations as perhaps we would like to have, and that left some flexibility for the administration. But I believe with this second round of federal funds, there are going to be more targeted recommendations from the feds, and I'm sure we'll look at that. And now this, on all of our committees, but the legislature certainly had a role in determining where that money went.
Well, I would say this committee had
Thank you.
Yeah, I think the Human Services, Healthcare, and the Health and Welfare Committees in House and Senate had a significant role to play in what happened. So and Senator Cummings, there you are.
Well, yeah, I'm on. Before Senator Terenzini runs off to sign up for joint fiscal, normally joint fiscal meets several times a year, once in July, and we have some limited ability. We get a lot of reports to move a small percentage of money around to respond to emergencies. The emergency board, which is the governor and the money chairs, also has, we normally don't do a whole lot, but the one thing we do have to do is approve all grants. The big reason for that is if the administration accepts a grant that runs for 2 years and we all have a new service, and then, oops, the federal money goes away and we're, either have to cut the program or come up with the money. So we watch that.
Understood. Thank you.
Okay, the 1.2 came in as a grant, and that's how joint fiscal became involved. And there was a certain amount that the administration could use, no approval. Second amount that they could use with approval, and then the bulk of the money was done through the appropriations process. And that's where all the committees of jurisdiction came in.
Thanks for the explanation, everyone. I'm sorry to slow down the slideshow, but this was very helpful.
You're not slowing anything down. I think it's very helpful for all of us.
It was a lot of money.
Yeah.
Certainly is.
Yes, and we're not done listing it for you yet, so Katie will.
Go right ahead.
Oh, did you finish this slide, Katie? Maybe you
I didn't. Nope.
Okay,
So I'm at the very bottom of the slide, and you'll see that 4.7 million was appropriated for food insecurity. That went to the Vermont Food Bank, and that language specified that it was for food and necessities such as diapers, toilet paper, and cleaning supplies. Subgrants were given to food shelves and meal sites, and additional personnel, supplies, warehouse space, and delivery services were funded with that appropriation. There was also a $12 million prior appropriation of CRF funds that was authorized for use for summer meal program for school children. Okay. So next, we're still in Act 136. There was a requirement for Dale to produce a report on meals for older Vermonters and other vulnerable populations. The General Assembly received that on August 18th of last year. There was $12 million appropriated for restart grants for childcare providers, for summer camps, and also for after-school programs. That money was used by the parent-child centers in relation to their COVID-19 costs, and also children's integrated services. And again, you received a report on that appropriation, how it was used on August 18th of last year. There was $2 million designated for grants to vulnerable populations, and the legislation specified that priority would be given to households below 300% of the federal poverty level, including families receiving Reach Up, older Vermonters, and individuals with disabilities. there was $700,000 appropriated to support new Americans, refugees, and immigrants. And that appropriation was divided in half equally to two organizations, the Association of Africans Living in Vermont and also Vermont's Refugee Resettlement Program. And that appropriation specified that the money was to be used for hiring outreach staff, including to assist new Americans who are interested in becoming registered child care providers. It was to be used for preparing and delivery of care packages and the navigation of case management services. Next, there was a $3 million appropriation for COVID-related public health precautions on Agency of Natural Resources land. There was a $750,000 appropriation to the legislative branch for COVID mitigation, including space and health safety needs assessment and a purchase of IT equipment. And there was a report that came in on that appropriation on August 19th of last year. And lastly, there was language about the Department of Health providing assistance with reopening independent colleges.
Okay, the next act is Act 140, an act relating to miscellaneous healthcare provisions. And this one requires the Green Mountain Care Board to conduct budget review for psychiatric care hospitals not operated by the state, which means the Brattleboro Retreat. And it has a gradual increase in the scope of the board's budget review, with full review happening by hospital fiscal year 2024. So that's really by October 1st, 2023. It requires limited Green Mountain Care Board budget review for the designated and specialized service agencies. Katie, do you want me to jump in? Parts? Sure.
It created a 23-member mental health integration council to help ensure all sectors of the healthcare system are involved in integrating mental health in the healthcare system. And this council is to meet every other month, beginning from October 1st of last year through January 1st of 2023. And a progress report, it was due December 15th, 2021, is due this coming year, and with a final report on January 15th of 2023. Also, this act set quality oversight measures as conditions of further state funding for the retreat and requires certain actions of both DMH and the retreat to support proactive, continuous quality and practice improvement and ensure timely access to high quality care. One of those requirements, there was to be a Department of Mental Health report on patient experiences and quality of care at the retreat. That's due on February 1st of 2021. And also, the Agency of Human Services and the retreat were to submit 2 reports on improving communications and relations with retreat employees. So the first of those 2 reports came in on October 1st of 2020. This was the interim report, and I know Joint Fiscal reviewed it. And the next final report comes in on February 1st of 2021.
Can I just interrupt right there on those 2 reports? That section of that act were actually written by this committee around the retreat around the employees. And I did meet with retreat folks as well as DMH when the draft report came out, and we'll look forward to the final report.
The act also expands V-Farm coverage. So V-Farm is the Medicare Part D prescription drug wrap that the state provides for Medicare beneficiaries with lower income. This expands the coverage that is available to, or will be available to, beneficiaries on the higher end of the eligibility scale, so that they have the same coverage as those on the lower end of the income eligibility scale. And this will be effective on the later of January 1st, 2022, or when we get approval from the federal government to do this expansion. More from Act 140. There are a number of prior authorization provisions. It requires health insurers to review their prior authorization requirements and to eliminate them as appropriate, and to do that at least annually with an attestation of their review due to the Green Mountain Care Board and the Department of Financial Regulation annually starting September 15th of this year. It has a DFR report due January 15th of next year on ways to increase the use of tools and to embed tools in electronic health records to complete prior authorization requests for imaging and pharmacy services. There's a requirement also due January 15th, 2022 for a report from the Green Mountain Care Board on an evaluation of opportunities for and obstacles to aligning prior authorization requirements under the all-payer ACO model. The Act requires health insurers with more than 1,000 covered lives in Vermont to start what's sometimes called a gold carding pilot program for prior authorizations. So this would automatically, it would exempt from prior authorization requirements certain providers whose prior authorization requests are routinely approved, and it requires at least a portion of these providers to be primary care providers in the pilot. And so this has to start by January 15th, 2022 with a report due January 15th, 2023. It has a requirement for a DIVA report on Medicaid's clinical prior authorization requirements. So not the imaging or pharmacy ones, but the clinical ones, due September 30th of this year. Then, and we alluded to this earlier, it extended and in some cases expanded certain of those requirements in Act 91. That was the one on the response to COVID-19. Those provisions allowing regulatory flexibility during and after the COVID-19 pandemic. This was the act that extended and or expanded some of those provisions, and we'll look more at that, as the chair said, in the coming days and weeks. It required a Department of Financial Regulation convened working group on coverage for audio-only telephone services after the end of the pandemic. That report was due on December 1st, 2020, and is available. And I think you also heard you'll be hearing more about that. And then finally, the Act directed VPQHC, which is the Vermont Program for Quality in Healthcare, along with the Department of Public Service and organizations representing healthcare providers and consumers, to identify areas of Vermont that have particular healthcare related broadband needs, and to identify opportunities to use federal funds or other funds to increase access to clinically appropriate telehealth services.
Just a heads up, I would, it would be helpful for you to look at the audio only report that came in, and so we can maybe talk about that when we get to our policy extension deadlines. And I did get information back from VPQHC, but so we'll try and circle back to that at some point.
Can I ask a question? What do you mean by gold carding? That the requirement about health insurance with more than 1,000 lives covered, at that provision. Could you explain that more, Jen?
Sure. So this would sort of pilot an approach that would exempt certain providers who have a good track record of having all of their requests, prior authorization requests, approved. It would pilot what would it look like if those providers didn't have to do prior authorization requests, either for a subset of services or for all services for a limited time. So there's often a lot of tension between the provider community and the payer community about prior authorization requirements. Providers don't like them in general and don't feel they're necessary, and they take time, they delay care, and they're administratively burdensome. Payers tend to favor prior authorization requirements so that they can be sure that utilization of services is appropriate, and that people aren't having tests ordered, for example, that aren't really medically necessary. And so this is, people are always looking for ways to find the balance between those two interests. And so one of the ones that has been talked about for a long time and is often called gold carding, which is why I put it here, what effectively, if you think about it, is giving a gold card, a free pass to certain providers for purposes of a pilot to see what the utilization among their patients looks like if they don't have to go through the prior authorization request, if if they have a track record of making appropriate requests.
Got it. Okay. Thank you very much.
Sure.
So Jen, I'm going to suggest that we move a little bit faster through some of these and do maybe the 6,000 foot level.
Okay, and we don't
Review.
actually have that much left because the last
Okay.
3 slides are bills that didn't pass, and we basically, on 2 of those slides, just gave you the titles.
Okay. All right. You, it's in your hands. Go ahead.
Okay. Act 142 is an act relating to the Maternal Mortality Review Panel. This is changes to an existing panel. It doesn't create the panel. It makes a variety of changes, including amending the panel's charge to include consideration of health disparities and social determinants of health, including race and ethnicity and maternal death reviews. It enables the Commissioner of Health to make one-year appointments to the panel if the expertise of somebody with a particular specialization is necessary on the panel. So for example, somebody specializing in substance use disorder or pharmaceutical management of mental health or social worker is necessary. The Commissioner of Health can have that person participate as a member for 1 year. There's also language that the panel cannot review a maternal death until the conclusion of any related criminal prosecution. It allows entry into reciprocity agreements with other states' panels, and it expands the records that the panel has access to. Previously, the legislation was tied to records needed when there is a public health issue at risk, and that language was removed, so it expands the scope of documents and records that the panel can review.
The next one is Act 155, an act relating to increasing the supply of nurses and primary care providers in Vermont. So the first thing this does is amend the requirements for the healthcare workforce strategic plan and require the Director of Healthcare Reform to maintain that plan in consultation with a newly created advisory group. The director has to update the plan and submit it to the Green Mountain Care Board by July 1st of this year for review and approval, and then to the full General Assembly by August 15th. And then it creates a couple of, creates or expands a couple of scholarship programs. It directs the Department of Health in consultation with the area health education centers at the University of Vermont College of Medicine to establish a primary care physician scholarship program that would cover the medical school tuition for up to 5 third-year and up to 5 fourth-year medical students who commit to practicing primary care in a rural area of Vermont or in a Vermont federally qualified health center's service area in a setting or practice not owned by an academic medical center. Somebody who receives the scholarship incurs a 2-year full-time or 4-year half-time service obligation for each year of tuition covered. And it appropriated funds from the Global Commitment Investment Funds, which means we get the federal match on those, and the state share was $277,500 of the $608,000 total amount for fiscal year 2021. It directed the Secretary of Human Services to identify funding sources for the state portion for future fiscal years, and there's a report on that due by March 1st of this year. And then it repeals this program prospectively on July 1st of 2022. So this was language put in by the Appropriations Committee along with some of the other provisions in here, so that there would have to be revisiting of this depending on the recommendations for the future state match. And then it appropriates a little over $1 million in Global Commitment Investment Funds. Again, the state share is much less, for fiscal year 2021 for additional scholarships for nursing students under an existing program administered by the VSAC, the Vermont Student Assistance Corporation. It gave first priority for students pursuing a practical nursing certificate, second priority for students pursuing an associate's degree in nursing to be a registered nurse, and third priority for students pursuing a Bachelor of Science degree in nursing. Applicants must have financial need, carry at least a 2.5 GPA, and agree to work as a nurse in Vermont for at least 1 year after licensure for each year of scholarship awarded. gives first preference for students attending an accredited post-secondary institution in Vermont. And it directs the Director of Healthcare Reform to identify the primary causes of Vermont's nursing workforce shortage and propose solutions to address them by March 1st.
That's a very small task by March 1st. It's like, we'll have to ask Ina.
Yes, and that was language added again by the Senate Appropriations Committee. Act 156 is an act relating to the Older Vermonters Act. It created a new statutory chapter entitled the Older Vermonters Act. There's a lot in it, but it includes principles for comprehensive and coordinated system of services and supports for older Vermonters. It addresses the roles and duties of the Department of Disabilities, Aging and Independent Living and the Area Agencies on Aging, often called the AAAs. And it requires Dale to adopt a state plan on aging at least once every 4 years, which is an existing requirement under the Older Americans Act, but this ties some Vermont requirements to that as well. And then it requires Dale to report annually on their adult protective services activities. There's a whole list of requirements for what they have to report, which is based on information that they already collect. And some of this has been reported in the past, but this codifies an ongoing reporting requirement. It requires the Secretary of Administration, in collaboration with the Commissioner of Dale and the Commissioner of Health, to propose a process for developing the Vermont Action Plan for Aging Well, to be implemented across state and local government, the private sector, and philanthropies. This Vermont Action Plan for Aging Well would help promote aging with health, choice, and dignity in order to establish and maintain an age-friendly state for all Vermonters. And it would also include a requirement for a review of the Medicaid rates paid to home and community-based service providers. The Secretary must engage with interested stakeholders in coming up with this process for developing the action plan, and that proposed process is due May 1st. And then finally, it establishes a 16-member self-neglect working group to consider issues relating to adults who, because of physical or mental impairment or diminished capacity, are unable to perform essential self-care tasks, and the recommendations are due July 1st, 2022. Next, we have Act 157, an act relating to expanding access to contraceptives. And the stated purpose of the act is to improve compliance with existing contraceptive laws and further expand access to contraceptives. It requires each school district to make condoms available for free to all students in their secondary schools. It directs the Department of Health, in partnership with healthcare providers and insurers, to communicate to adolescents and others of reproductive age information about both access to contraceptives and health insurance and other coverage for contraceptives. And it requires the Agency of Education and the Department of Health to report back by April 15th on the status of their continued efforts to support schools and school districts in providing comprehensive health education, including sexual health and safety, to Vermont students. Getting close to the end here, we've got Act 159, an act relating to increasing hospital price transparency, hospital sustainability planning, provider sustainability and reimbursements, and regulators' access to information. And this is previewing some information that will be coming your way in the near future. So it requires the Green Mountain Care Board to develop and maintain a public, interactive, internet-based price transparency dashboard so that consumers can compare prices for certain healthcare services across Vermont. They have to give a progress report on their development and implementation of the dashboard by February 1st of this year. And they're going to do a dashboard demonstration and provide recommendations for future expansions of the dashboard by next February 1st. It directs the Green Mountain Care Board to consider ways to increase the financial sustainability of Vermont hospitals to achieve population-based health improvements while maintaining community access to services. The first update was due on November 15th. Second update is due this April 1st, And the final recommendations are due by September 1st, with a possible extension to the middle of November if needed due to COVID-19 considerations. It directs the Green Mountain Care Board to identify processes for improving provider sustainability and increasing equity in reimbursement amounts among providers. Again, an update was due by November 15th, and identification of the options with the most potential is due by March 15th. It requires health insurers to provide to the Green Mountain Care Board, upon the board's request in connection with a health insurance rate review, detailed information about payments that the insurer makes to specific providers, and proprietary information would be kept confidential. It also specified, it was pretty much already in law, but specified that individually identifying information submitted to the Green Mountain Care Board as part of the hospital budget review process must be kept confidential. It allows the Green Mountain Care Board to examine and discuss confidential information outside of a public hearing or meeting. It clarified the Department of Financial Regulations emergency rulemaking authority with respect to COVID-19 diagnosis, treatment, and prevention. And it delayed the date for the first meeting of the Mental Health Integration Council from October 1st of last year to January 15th of this year.
Next is Act 161, and this was a response to COVID. It allows for full-time care at a family child care home for school-aged children who have the option or otherwise are scheduled for remote or electronic instruction off school premises. So the problem this was trying to address is in the statute before this was passed, a school-aged child could only attend a family child care home for 4 hours. And if a child were to be receiving electronic instruction off the school premises and their family members had to go to work outside of the house, that there would be no place where the child could receive care necessarily. So this expands the hours that a family child care home could take in such a student, a school-age student. And there were other exceptions for snow days, for school vacation days. So this is just one of the exceptions. And you'll see that this is a time-limited provision. It's effective until September 1st of this coming year. The next bill is a bill that you did not have possession of, but that you did review. This enables individuals who are placed in a hotel, motel, or lodgings in connection with medical treatment or recovery services that are paid for by a hospital or a DA or an SSA to remain housed in the same setting without establishing tenancy. The problem this was trying to solve was that previously individuals who were receiving this type of care were removed overnight to avoid creating a tenancy and then moved back into the hotel or motel to continue receiving their treatment. So now there's a carve out essentially that prevents these types of individuals from establishing tenancy when they're staying at a hotel or motel for this type of care, so they don't have to be moved and have their care interrupted.
Okay, and then we have highlighted for you from the budget bill from 2020, or the FY21 budget, some healthcare and human services related budget provisions we thought you should be aware of. The first deals with our global commitment waiver. This authorizes the Secretary of Human Services to seek from the Centers for Medicare and Medicaid Services a no change extension of our existing global commitment to health Medicaid Section 1115 demonstration for the period from January 1st, 2022 through December 31st, 2023. And if CMS does not approve a no change extension, then it would give authorization to seek an extension for the period, effectively a new waiver, but with changes for the period from January 1st, 2022 through December 31st, 2026, or an earlier date. Another section allows the Department of Vermont Health access to establish a preferred drug list for HIV and AIDS related medications, which had previously been carved out, but it has some parameters in it that apply not just to HIV and AIDS related medications, but to all medications on the preferred drug list. that would allow patients to use drugs not on the list if it is clinically appropriate to do so. So this was seeking to address some of the concerns from earlier years about including the HIV and AIDS drugs on the preferred drug list. And for insulin, this was actually a bill sponsored in the Senate by Senator Hooker on insulin. Starting in 2022, it would require health insurance plans to limit patients' out-of-pocket exposure for prescription insulin medications to a total of $100 per 30-day supply of all medications. This had been a standalone bill in Senator Cummings' committee. They had taken testimony on it. It was added to the budget before it passed. And we can talk at some point, if it's helpful, about the effects of this. Unfortunately, because of the self-funded plans that the state is preempted from regulating under the federal law known as ERISA, this provision may not have a much of an impact for most Vermonters. But we can discuss more if that would be helpful. And Katie, do you want to talk about the last bullet?
Sure. There's another provision that directed the Department of Mental Health to explore strategies for collecting data related to persons accessing emergency health services related to a mental health crisis. That report is due on September 1st of this year, and it requires collaboration with the Director of Racial Equity and the Mental Health Crisis Response Commission and DPS.
And then finally, we have given you some bills that passed out of committee but were not enacted. And some of these you spent a considerable amount of time on. So we wanted to just flag which ones these were as well.
So for starters, there was H531, which was a pretty comprehensive childcare and early learning bill. And this committee spent a lot of time on it. While the bill itself did not pass, many portions of the bill were pulled out and put into the budget bill. So I wanted to flag for you what those provisions were. There was a provision that enables families seeking employment to participate in the Child Care Financial Assistance Program for up to 3 months or longer with the commissioner's approval, versus previously it had been up to 1 month. There was also a fiscal year 20 CCFAP adjustment, CCFAP being the subsidy program, Child Care Financial Assistance Program. So adjustments to the sliding fee scale and market rates. So the preschool and school age rates would be the 2014 rates, and the infant and toddler rates were the 2017 rates. Again, this was fiscal year 2020. Next, in E318.3, there was a $1 million appropriation for childcare stabilization grants, including to support programs that maintain the enrollment of children receiving support through CCFAP at a level of at least 50% of the total enrollment, and also to expand infant and toddler childcare capacity. There was, in addition, a $100,000 appropriation in fiscal year 20 for developing and implementing a modernization plan for the IT system that the Child Development Division uses, the Bright Futures Information System. In fiscal year 20, there was a $300,000 appropriation for grants to incentivize child care professionals, including hiring and retention bonuses and tuition assistance for continuing education. And lastly, in fiscal year 2020, a $300,000 appropriation for implementation of the Council of Professional Regulations Child Development Associate Credential Curriculum in technical centers.
So I want to reiterate what Katie said about these provisions. We actually had a bill in our committee introduced, and the House also had a similar or the same or similar bill on early child care, early learning and child care. And the House does have the luxury of all-day meetings. So they worked very hard on that bill and synchronized with their appropriations committee. When we got the bill, we made significant changes and worked with the administration to look at market rates and CCFAP and everything else, and made decisions that then were carried to the big bill into the budget. I think we'll also be seeing, we will be seeing a bill on childcare this year. One of the areas that's really going to be important is on the IT, the technical stuff. So we'll see what we get. And we don't know yet, as I've said before, whether the childcare bill is going to begin in the House or the Senate. But of course, the House does have that advantage of being able to work longer hours and integrate their results a little bit better as a bill with money in it, with the approval of appropriations. So we'll see how that goes. It's always fun. Thank you, Katie. That was great.
All right, and then I'm just going to run through the titles of these. We have 2 slides on the bills passed out of committee but not enacted. So there was H249, an act relating to the Reach Up and Reach Ahead pilot program. S42, an act relating to requiring at least one member of the Green Mountain Care Board to be a healthcare professional. S65, an act relating to banning baby bumper pads. S94, an act relating to expanding Medicaid beneficiaries' access to dental care and establishing the VDent Dental Assistance Program. This was a bill proposed by Senator Hardy, and similar language was included in the FY20 budget bill. S125, an act relating to Vermont's adoption of the Interstate Nurse Licensure Compact. S141, an act relating to nutritional requirements for children's meals. S181, an act relating to access to employee restrooms for individuals living with an inflammatory bowel disease. S185, an act relating to adopting a climate change response plan and regional planning commission involvement in identifying healthcare related needs. S197, an act relating to prohibiting discrimination based on genetic information. S218, an act relating to the Department of Mental Health's 10-year plan. S243, an act relating to establishing the Emergency Service Provider Wellness Commission. S252, an act relating to stem cell therapies not approved by the U.S. Food and Drug Administration. S288, an act relating to banning flavored tobacco products and e-liquids. S295, an act relating to restrictions on, should I have Katie do this one, perfluoroalkyl and polyfluoroalkyl substances and other chemicals of concern in consumer products.
PFAS.
PFAS. S297, an act relating to the Agency of Healthcare Administration. And S302, an act relating to establishing a mental health mobile response unit pilot program in the city of Rutland. That's it. End of presentation and end of bills.
Yeah, okay, but wait, didn't S302, the mobile response, didn't that actually, something happened to that? Didn't that get handled
I
in a
remember. It definitely passed out of your committee. I don't know if it got absorbed into the budget.
I'm trying to remember. Or I think there was, I know. Was it linked in with the SAMHSA grant, the $200,000, and they found the money?
Be.
Yeah,
That could
okay.
be.
So, I mean, I think the 2 people who will be most concerned about this are sitting right here. We've got our 2 Rutland people. We'll sort, maybe Katie, you could help us sort that out at some point.
Sure.
Thank you.
So
Senator.
as you can see, we did accomplish a great deal last year. A lot of the bills that we passed out that weren't acted on were bills that were passed out before March, before COVID hit. And then after that, we devoted our whole lives to the other bills that you saw. So now we're doing it in the reverse. And we're going to spend time on COVID pandemic stuff, and then the bills, some of the bills that we have in committee are bills that didn't get completed last time. And some of those bills are very much related to pandemic on a secondary level, not the primary funding piece, but on a secondary level. So I'm hoping that we can take some of those bills up before crossover. Josh, you had your hand up.
Yeah, Senator Lyons, thank you. I just scribbled some notes of bills that we just quickly went over that didn't make it. And there's a few that I just would have questions about. I understand we're up against the clock here this morning, and I can hold my thoughts for another time. But if I understand correctly, you just said, Senator Lyons, that we will revisit that list of bills that didn't make it out.
Yes, yeah. So a lot of those bills have been reintroduced, and a couple of them made it partway, either from our committee to another committee in the Senate, or made it all the way over to the House. And so in negotiations with the House, we're talking about which of these bills starts again where. So we will be taking some of those bills up, and we haven't gone through the bills yet, so it'll become clearer to you as we discuss them, which ones might be more appropriately related to COVID.
Okay,
I don't
thank
know
you.
if that answers your question or not.
Yeah, I think so. I can also
Okay.
ask my questions. The wheels
Yeah.
are turning. So
Okay, that's a good thing. We like to see the hamsters running. Yeah.
And feel free to be in touch with Katie or me if we can be helpful in talking about, helping you understand what the bills were or where they went in the process.
Wow, thank you. And Katie left, but thank her too. Thank you, Jen. That's a significant amount of work that you have just put in front of us, and it is extremely helpful. Any other questions? Oh, please go through that all again. That's
Okay,
so.
I'll take it from the top.
Yeah, no. Well, there are some of those bills that we have looked at that we passed that are pretty significant in terms of moving forward on some healthcare reform in some healthcare reform areas. And some of those bills obviously are significant in terms of prevention and primary care. So we'll take other steps forward, hopefully this year. Senator Hardy.
Thank you. Jen and everyone, a lot of those bills, just in general, a lot of bills that we pass require reports of some kind or another. And we must be so irritating to many other agencies asking for so many reports, but they're hard to keep track of in all of my committees and just across it. And I know you have a list of reports that you've provided us.
Yeah, we're going to go over that on Tuesday, I think.
Okay, great.
Next week we
Yep.
we got into the reports.
And there
Okay.
are links in it so that you can click.
Okay. I just don't have enough bandwidth to read every single report. So it's great. It would be great to sort of the ones that have recommendations that we might want to act on. If someone is able to flag them, say, this is definitely a report you need to read or something like that. That would be
So, yep. So I did some of those for you today. The one on the primary care report that was due in 2020. That's one to make sure you look at. And I'm looking at the other one I identified for you. The Medicaid, there was a Medicaid report as well. But when we go through the reports on Tuesday, we'll flag some. And as you hear, I think Jen and Katie will sort of give us the 10,000 to 6,000 to 10,000 foot overview, and we'll see maybe some of the executive summary. And we can decide maybe individually who wants to look at which report, and then collectively we would all look at some of those. So we'll do that.
That sounds great. Thank you.
Yeah, we'll do that. Well, we're not going to go into every report in committee. That doesn't make sense. I mean, so there will be some time for you outside of committee to look at some of those. Any other questions? You're just trying to leave early, I know. And we all deserve it. I have to say that it's been coming back into session and working a full day on Zoom is not an easy task. And you guys have been great. We'll keep at it. We want to keep doing, we want to be productive. And we want to do things that are going to help improve healthcare for folks and provide community services for them. So, anything else? So you have a little bit of a picture for next week. Reports from Jen and Katie we'll look at on Tuesday. Depending on how much we accomplish on that day, we'll always put some more reports on other days as we have time. On Wednesday, we'll be hearing from our healthcare reform director, Ina Backus, and we can see where we are with healthcare reform. Then we'll also be hearing from Vicki Lohner of One Care, our affordable care organization, so you can begin to get your feet on the ground about the difference between our healthcare reform package that Ina talks about and then what that means with respect to the ACO. So there's a lot there. This will be your first crack at it for some of you. Ann and I, the Senator Cummings and I have visited with One Care and heard about them many times, but it doesn't hurt to go back and listen again. Then on Thursday, I've put a number of folks on the agenda who we tend to hear from on specific issues, organizations and individuals who are very important to informing our decisions. So you'll see who they are. And then I forgot what Friday is, but you'll see the agenda. It'll be Nellie will have it up pretty quickly.
I think Friday is childcare.
Oh, I think you're right. Thank
Yeah.
you.
Yeah.
Yeah. That's good. We're going to take a little bit of a dive into childcare just to understand where it is right now and what our programs are in the state. So we'll have folks from DCF coming in and talking with us. Okay. Anything else? Okay, in the fine tradition of Senate Health and Welfare, we have finished early and we're on the floor at 11:30. Unless you have another topic you wish to discuss, we're fine. Okay.
Bye,
Thank you
everybody.
all.
See you soon.
Thank you all. If I don't see you again today, have a great weekend.